Well, thank you, and thank you for inviting me. Two disclaimers to start with. Firstly, while my CV does contain some clinical trials that I've been involved in, some of them not glorious in that regard, I'm primarily a user of clinical trial information, both as a sort of in a policy setting and in the sort of resource decision making in my role as the chair of the PBAC and with MSAC to a lesser degree. The second disclaimer I have to give is that you might have noticed in the recent reshuffle in the national government that there wasn't a special envoy for the PBAC with my name against it. I say that because the things I say today should not be taken as being any sort of implication of policies of the Commonwealth Department. Okay, so let me just start with an acknowledgement to the traditional owners of the land on which we gather and elders past and present. This is a painting from Rosella Namuk, who lives in the Lockhart River area in North Queensland, and I always take the opportunity to promote the art from North Queensland, which is where I come from, because it doesn't necessarily get the same profile as other art, other Aboriginal art. So today, what I wanted to talk about is what clinical trialists should know about healthcare policy. So unfortunately, you should never ask somebody who heads something called the Menzies Centre for Health Policy to talk about health policy, because clearly you're going to get Health Policy 101 as part of that. I'm going to sort of extend a little bit what Jeremy's been talking about in terms of evidence and policy and how that influences in the policy-making process. And then I'm going to just use some examples from the PBAC processes to illustrate what I'm talking about. So let's just start with some really basic things, because I think this is really important when we think about what we're gathering evidence for, which is really what we're on about, whether it's clinical trials and other forms of research that we might do. We're trying to inform, generally speaking, some sort of decision-making process. So why does government bother investing in healthcare? I mean, it's so basic to us that government spend money on it, we don't even ask this question. It's particularly, if we're clinicians, we think this is something that of course you do, but it's not actually as straightforward as that. In fact, governments invest in healthcare for a range of reasons, and this is just sort of setting out some of them. We invest in it because we know it's a major cause, ill health can be a major cause of inequality. We do it for the public good, the investment for population health reasons. And we do it because healthcare is a very important industry. It's probably the only fast-growing industry we have in Australia at the moment, other than the university sector. So there are good reasons for investing in it for that reason. But these are decisions that government will make around this. There are some principles that we have to sort of think about when we think about what we're talking about. And the first of those is that in healthcare, at least, demand is infinite, the resources are not. Demand's driven by the new technologies, the ageing of the population, increasing consumer demands, more chronic disease, and various health systems, i.e. provider incentives that are out there for health providers to actually do more things. Equally, as part of that is that the health system has a responsibility to demonstrate that the existing resources that allocation and utilisation is appropriate, effective and efficient. That is one of the things that drives me when I think about the process of generating research, generating evidence for the purposes of informing decision making. And we have to be cautious in this process, I think, that when we go seeking additional funds, we do it for the right reasons and not just as a matter of shroud waving. Jeremy sort of touched on this, and this is a different way. This is sort of health policy way of thinking about the issue of who the decision makers are. And it's thinking about that different level of decision making that you think about from a health policy perspective. And we talk about the sort of macro level, the level of resources allocated to health services or to health improvement relative to other sectors in the economy. We talk about the broad distribution of resources between different populations, geographic areas or different types of services. We talk about the specific allocations to particular forms of treatment or health gain. the choices of patients and consumers in terms of the access to services and the decisions on what to provide to individual consumers or patients. These are all different levels, a different way of thinking about that decision-making process that we have. And diagrammatically, if you think about government spending in healthcare, you can think about it in this way, that at the sort of top level it makes decisions about how much money it's going to spend on health versus education. Then within the health sector we make decisions about how much we spend on treatment versus preventive services, and then within the curative services. And you can see the cascade that we get down, right down to the bottom here, which is where those decisions that clinicians make every day in the decisions with patients and in terms of what they're going to do. Another fundamental principle that you have to bear in mind when you think about health policy is the issue of opportunity costs. I know it's something that I'm sure you've heard the term before. Every healthcare intervention uses resources which could have been used for another purpose to produce another potentially equal desirable outcome. Health resources that could have been spent on other ways to improve health, for example, through better education roads. Those are things which can also generate health values. They are decisions about treatment resources that are spent on cure versus prevention, and then within that, within the treatment arena, that treatment resources that could have been spent on different types of patients, on different types of conditions, on surgery versus medicines, etc. Every time we make those decisions, it is a finite pot that we're talking about. It may not seem like it at times because governments continue to throw money at it, but it is a finite pot. There are decisions being made all the time. And that sort of comes to the next sort of principle in health policy, that is, decisions must be made. Available resources are rarely enough to meet all that growing demand, so choices and decisions have to be made. We put language around it, nice language around it, so we talk about priority setting rather than rationing, but it's about necessary choices. And the only real choice is whether that decision-making is explicit or implicit in the decision-making. How much do we actually acknowledge that we're making those choices in terms of what we do? I term these the Wilson principles. Decisions will be made, and I think it's our role is how do we best inform them? And that's really the thing that drives me in my sort of interests in research, is how do we best inform those decision making? Over more than 30 years now that I've been involved inside of government and outside of government, that is trying to understand what it is that motivates people to make decisions in different ways. We have to recognise that some voices are heard more than others, and we have to think about who's carrying our message and how we get that message across. We often laugh about the fact that governments say, oh, we're not going to make a decision, we're going to invest in some more research. Well, some of the time we should laugh at it, because some of the time it is a bit of a joke. But it is equally a legitimate policy option. If we don't know what the best decision is, maybe we should get some more information about it. And we might want to talk a little bit more later in the day about the role that modelling can have in that decision-making process. And then the last one is that timing is an essence. We might think of ourselves as having a research career of 30 years or more. Let me tell you, most decision-making, certainly most significant decision-making in government, is made in the span sometimes of seconds, as we've seen with sort of allocation of money to reef resources. In other situations, it can be drawn out, as we've seen. The reality is that when we think about the policy cycle, that decision-making process, and you think about the three sort of main aspects of that the politics in health policy is a dominant feature of what actually happens. So you can't be involved in health policy without understanding the politic of what's going on there. Of course, we'd like to see that back wheel, the evidence, grow in its importance. And I think that's something that we have to work at in making sure that that evidence is there. We also have to think about the drivers at the top. Who's doing it, and what are their interests in terms of steering what's actually happening, and how do we influence what they're trying to do in that setting? Now let's move on to the issue of evidence and policy. And this is a quote came from the Journal of Royal Society of Medicine, this paper by Klein, and I think it just really captures for me the essence of what we have to think about when we're thinking about policy. different types of policy and different stages in the process call for different types of evidence. So we've got to focus today on trials and clinical trial design, but it is not the only type of evidence which is important in the decision-making process. Sometimes we want that evidence from cohort studies, from observational studies about the real-world settings and what actually happens out there. Sometimes we need information about public opinion and how the public views these different things if we want to inform these sorts of decisions. And at the patient level, at the clinical level, those issues around patient preferences and patient inputs are a very important part of what things that we should consider in our clinical trials. There's a good set of tools that I'd like you to refer you to. They're called the support tools, and it's in the Journal of Health Services, Health Research Policy and Systems, and it describes the whole process of how evidence can be better informing health policy. And it's a series, I think there are 8 articles in it. It's a very easy read, and if you can't be bothered to read all of them, just read the summary article, which captures most of the essence that are there. And you can see there already, just looking at that, reinforcing many of the points that Jeremy was making before about the importance of evidence synthesis as part of the decision-making process. I've just picked out a few of the principles there that I think apply particularly in terms of clinical trials and in the interpretation of clinical trials. We tend to poo-poo the issue of expert opinion, but expert opinion remains an absolutely critical issue in health policy terms. Expert opinion is more than just the evidence. It's the combinations of facts, the interpretation of those facts, and the conclusions that are drawn about them. And the process of how that expert opinion has arisen is as important as the evidence that sits behind that. Equally, we have to remember that not all evidence is equally convincing, and we have to think about the contextual nature of the evidence. I actually didn't answer your question about the 20,000 versus the 4 by 5,000, because I think there's a much more nuanced aspect of that. Because if you offer me a 20,000 person trial set in 8 countries, then I might say actually that's probably the best outcome, because there I'm going to see those different areas. Whereas if you give me 5 trials set in the US, I'd almost certainly dismiss it in terms of its implications for the rest of the world, particularly in the current moment. We have to think about the judgments about how much confidence we can place in different types of evidence, and that's a really critical issue for us, for example, in making decisions for the PBAC, trying to understand the certainty and uncertainty in some of these issues and how much that's explicit. We have to think about the context, that evidence is context sensitive, and I think Jeremy's made that point well, so I'm not going to labour it here. But the importance of local evidence, and I think, I think the investment in ACTA, the investment in some of the other trial infrastructure in Australia is a really big step forward for us in Australia, because it's going to give us the ability to collect a lot more local evidence around a number of these issues that apply in this space. Another way of saying the issue around the synthesis of information is that the last point there, that judgments about whether to base a conclusion on a subset of evidence of observations when we're trying to think about, well, does it apply to my patient or my patient group in that regard, should be seen within the context of all the evidence that's available, not just in isolation of one particular trial. Again, just some pragmatics of health policy. You have to think about, you need to understand who the decision makers are in relation to this. So if you think about what happens in a budget context, again, I'm just talking at a sort of very macro level here. Departments prepare budget proposals, and they include a whole range of priorities and potential offset savings for ministers. National governments operate in Australia on the basis that in the main new initiatives will be found within the budget of the particular host department. So if you go along saying we want to spend some more money on this, their immediate reaction is, my God, how am I going to find that money to fund that? The ministers approve the budget proposals, including priorities. They go to a budget committee, which then looks at those and makes the decisions around those things. All of those are important steps when you're trying to influence investment in those decisions. So you have to think about that. This is my sort of assessment of what decision makers in a health policy sense are looking for. Again, so what are the real benefits? Has there been some sort of formal technology assessment of the evidence in that regard? Who's going to benefit from this? That's a really important question in the political sense. What are the real costs? That issue that Jeremy was talking about before of, okay, well, so we're going to buy this new drug, but what about the fact to target this new drug that you're going to have all this other new diagnostic technology? What about if we want to give thrombolysis to patients with stroke? I think the actual answer now is it's out to 11 and a half hours rather than 4.5 hours. But exactly. We need to think about what are the alternatives, what are other things, that opportunity costs, what are the other people who are in there vying for funding in this situation. Are there other ways that this could be funded that we need to think about it? And then we need to also, again, just coming back to this issue of, in terms of getting support for it, who supports it? Is it a single department? Is it a discipline? Is it a centre? Is there a coalition that defends it? What makes the difference? The business case sets out information needed for the decision maker, such as relative effectiveness, potential efficiency gains, real costs, those sorts of things. As I've already sort of pointed out, the issues around understanding the budget environment in terms of what will actually get up in relation to that. When I worked in senior roles in government, what were the things that that got me excited, that I knew I could sort of champion something? So changing models of care, that was something which gave me an idea that we could actually change the way we do things in a way which improved outcomes and efficiency in terms of what we did. The size of the patient benefit obviously is really important. If there was sort of cross-disciplinary support, if it was not just one craft group that was proposing this, it gave me a greater sense that there were likely to be formal changes, those sort of health technology issues, addressing inequity. These are sort of things that I think, in general, people who are in senior sort of roles think about when they're considering whether or not this is something you want to go out on a limb to support. Now, last part, I just want to talk specifically, just use the PBAC decision-making process to give you some sort of context for this. So when we're thinking about decision-making in the PBAC, we have two sort of groups of factors that we consider. We talk about the quantifiable and the less quantifiable factors in relation to that. So in that quantifiable category are those things that we normally associate with clinical trials. So what's the comparative health gain, the comparative cost effectiveness? There's an issue around the patient affordability, the predicted use in practice. That's important, those two last ones, in terms of telling government how much it's going to cost. Then there are a range of less quantifiable factors, and it's interesting that we use the term less quantifiable because it's not that you can't do any measurement on them, but the measurements are much less absolute, if you like. So things like the overall confidence in the evidence and the assumptions relied on in that submission. I mean, we see applications, proposals put to us where we'll frequently see data presented from maybe a 12-week trial extrapolated out to 10 years. How much certainty can we place on that extrapolation and in terms of the overall benefits? Issues of equity come up again, the presence of effective alternatives, the issue of what's the severity of the medical condition treated. If you've got the condition, you think it needs to be treated. How do we do that in a way which is fair and equitable? The whole area of ability to target therapy is an absolutely fascinating area, which clearly with the genomics, with the imaging technologies and a whole range of other aspects is making this a really interesting and challenging area in terms of how we incorporate that and what it actually means in our decision-making process. The context that the decision maker works in, I just have to emphasise this, that the context of which the decision maker works in is critical for you to think about when you're generating the information. So if you wanted to influence us in terms of the PBAC, it's not, the issues that you have to recognise is that under the Act in which we act, and it's actually written into the Act, when we recommend it to the Minister a medicine for subsidy under the PBS, we're required under the Act to consider the effectiveness and the cost of the proposed medicine compared with existing alternative therapies. We cannot make a positive recommendation for a medicine that is substantially more costly than an alternative medicine that is satisfied that the proposed medicine also provides a significant improvement in health for some people. That's what the Act says. So in our decision making, that's what we have to take into account. And if you're trying to provide evidence for us, that's what you have to think about that for the context in which we are in relation to that. There are things which that's written in the legislation. There are also things which government set parameters for. So through its policy decisions, it sets other parameters that inform our decision making. So, for example, the policy is that a medicine is not recommended for listing unless it's registered by the by the Therapeutic Goods Administration. That's a decision of government that it will not list, that we shouldn't recommend drugs where there isn't a TGA approved indication. Just a couple of other points to illustrate these sorts of issues. So when we're thinking about the issues in comparative health gain, that's something that's obviously at the core of a lot of clinical trial works. So Jeremy talked about the issue of the minimally important clinical difference and what that can make in different contexts. I also like to think about the idea of the minimally important patient difference, that what a clinician thinks is important is not necessarily, an important difference is not necessarily the same as what a patient thinks is important in relation to this context. And then from our perspective, from the PBAC process perspective, and for that matter for the MSAC processes, we have to think about the overall value that relates to it. This issue of uncertainty and trying to understand that around the cost effectiveness, these sorts of issues are things which you'll need to think about in the clinical trial design situation. One of the challenges we have is that we're getting data increasingly earlier coming to us for decision making, where the data is immature, where we've got surrogate measures which may or may not be of great certainty around the extrapolated benefits. We have the whole issue of a lot of the trials which are done at the point when they're coming to the pharmaceutical benefit scheme actually haven't been trialled against the comparators at all. So we're actually very uncertain about the comparative benefit, the comparative gains. The issue of crossovers in trials, an increasingly challenging issue. This is where patients get to cross from the comparator arm to the active arm. We've got trials where that we're being asked to make decisions about where 60% of patients will have crossed over in the follow-up period of time. What does that mean? How do we understand that? The place in therapy and the duration of therapy, these are really critical issues. For example, in the checkpoint inhibitors in cancer, how long do we need to trial these? Do we need to treat patients with to get the benefits from these in that regard? The issue of patient populations, this is one which I think is we really just have not come to grips with yet. Most trials still exclude the populations at highest risk, that is the elderly, and we have very few trials which involve children. We have to address particularly the former one. The children one I think is problematic, but the elderly one really is a question of being more pragmatic in our design of these trials. And a whole new area of, not new area, but becoming a hot topic for us around combinations, which, when, what order, what evidence goes with those combination therapies is a really important and hopefully one that the clinical trial community in Australia will take on with some issue. Again, I've just chosen out one issue here was from the less readily quantifiable factors, and I talked about the targeting of therapy and some of the issues that rise here. So you have issues like the cost effectiveness of proposed medicine may not be in patients likely to benefit the most. So we see that all the time in terms of where companies position their drugs for subsidy on the PBS. We have to think about the extent to which the targeting of patients was actually a deliberate part of the design, or was it a post hoc decision where analysis on these trials. So yesterday I met with one of one of the large pharmaceutical companies, who said basically their standard operation now for every patient who goes into one of their trials, they collect DNA. And they now just retrospectively do analysis on all of that to try and see if there are subgroups, etc., using DNA markers of different types. We have to sort of think about the effect of whether the markers are absolute or graduated. This is quite an interesting area at present. Again, coming back to the checkpoint inhibitors, when we started with this was a whole issue of, well, whether you just needed to be positive, just have any PD-L1 expression, or do you have to have a certain level. That has really a major importance in terms of subsidy decisions, because if you decide that you have to have 50% expression of PD-L1 in your tumours, well, what happens if the patient's 49%? Well, the first thing you can say is almost certainly the pathologist is not going to report it as 49%, he's going to report it as 51%, he or she, as the case may be. But there are also issues of patient groups who will say to me, well, look, this is an equity issue, why can't we have access to this just because it looks like it performs a bit better in those who have got higher expression? And anyway, it may turn out to be not as important as we thought it was anyway. So these are the sort of some of the core questions in a very rich world that we have. I've just chosen this because it just, in my sort of reading on the weekend, I just thought it was a lovely example that illustrated the sort of this challenging, the difference between how policymakers, particularly people who are in the business of reimbursement of drugs, think about things versus how other people, how clinicians might think about this. But it also, it was to me a fascinating contrast interpretation of the trials. So this is from the Lancet this year. It's the article and the comment down there. So the abstract, just to summarise it, the abstract conclusion was Pembrolizumab did not significantly improve overall survival compared to paclitaxel as second-line therapy for advanced gastroesophageal junction cancer, etc., etc. And then in the commentary says, from a utilitarian and funding perspective, this approach is less attractive because 5 of 6 patients do not appear to benefit from the Pembrolizumab. Now, I think there's a very interesting and a whole range of issues that arise from this interpretation of what goes on in relation to it. But it is actually a very lovely summary of the perspective that decision makers, particularly reimbursement decision makers, have to make in relation to that. So, my takeaway message for you, you need to be clear on what decisions you're trying to inform, who will make that decision, what is likely to influence them, and what's their decision latitude, what's the context in which they make their decisions for that. We need to design studies that will fill that evidentiary need of the decision maker, so thinking about where that's at, and we need to recognise that policy decisions are not made on evidence alone. We need to think about what's the total information need that will inform that decision-making process. So thank you for that.